What a year 2020 was, right? If anything, 2020 has taught us it's that we need to take care of ourselves, our mental well-being, and everything. Now, there used to be a joke, or people used to joke that she's hormonal, it's mood swings and all that. It's not funny when it comes to thyroid patients because when it comes to us, you really cannot control it. Depression, anxiety, insomnia, and all that just comes with the territory. So imagine pandemic plus that. 2020 was basically that for me, and then I got pregnant. So go on this journey with me as I talk about my journey that was thyroid healing and then all the way through pregnancy. And I hope this helps you in any way possible if you're going through something similar. Anything you want me to ask anybody or ask me, please comment below. I look forward to hear from you. So what is thyroid? Let's get to know that with my endocrinologist right now.
Okay, let's talk about something I've been holding off for the whole of 2020 because I thought I was going to get over it and get on with life. The end of 2019 going into 2020, I found out that I had thyroid, and it's thanks to this doctor that I knew it was thyroid and that it had to be addressed. So end of December, very drama, end of December, I wanted to go camping, but my heart felt terrible. I felt like I had a heart attack if I even knew what a heart attack was. And I went into emergency to meet this doctor because his clinic was full. So his nurse actually told me, try emergency. That's what I did. I went into emergency and I told him my eyes were bulging out. They felt extremely tight, if you can say that, and very dry. And my heart was going crazy. So I didn't know what a heart attack was, but it felt really close to it. I was always very hot. I was skeletal. I was anxious. And all these you will come to know as the symptoms of hyperthyroidism. And this is the doctor that attended to me and who has been with me since, Dr. Saiful, I call him. Dr. Saiful Bahari Kasim, consultant endocrinologist and diabetologist at Gleneagles, Kuala Lumpur. So as much as I didn't want to be in a hospital during COVID time, I was there the whole of 2020. The only thing that made it better was this man here. So hello, Dr. Saiful.
Hello, Serena. Good to see you.
Yes, good to see you. It's always good to see you. You're the light at the end of the tunnel, when I'm trying to maneuver through this thing that is thyroid. So for the next few episodes, we'll try to understand what thyroid is. But to give you a clearer picture, this is a thyroid patient. I was hyper as hell. End of 2019, December, doctor brought me down to hypo with drugs and then stabilized me. And then when I was stable, I got pregnant. So here I am, 21 weeks pregnant now, and it's supposed to be a good thing, and we'll see why. So I went from hyper to hypo to stabilize. If I didn't get pregnant, doctor, where would I be now? Stabilized?
I think it would be in that narrow spectrum of between hypo and hyper, and we try and keep it between that narrow spectrum.
Yeah. Oh, so you mean we'd be trying to keep it within that spectrum for roughly, can you give me a gauge? How long do we need to keep this going on, or is it for life?
Yeah. So usually the therapy that we try and keep it at that is about, the aim is about 12 months during the treatment, and try and keep it between those two levels.
Yeah. So I would be on drugs for about 18 months, and then after that, do you taper it or do you cut it off?
We try and taper it. Indeed.
I see.
So I think to be on the safe side, we always say that in thyroid therapy, it's a not sprint, it's a real marathon, and the idea is by the time we hit about 6 months, we should be on auto cruise mode. But before that, it's a bit like being in choppy seas. You might go from hyper, as you said, to hypo. Because the idea is you want to give the appropriate dose of a drug to suppress the production of hormones from the thyroid gland as much as possible. And so you go from high to low. And then once you're at the lower end, you try and bring it up to the normal range. Why we do that is to allow you to give you the best chance of a remission from thyroid disease. It's very hard to use the word cure for thyroid disease. You try and put into remission, and remission is for the rest of your life. And if we don't get it right, if we try and bring your thyroid down gradually, there's a higher risk of a rebound. So in thyroid disease, it's like shock and awe. You shock the system, you bring it from over down to low, and then you gradually tip it back towards a normal range. That's the art of it, the difficult part of getting it right. And every patient is different. And thank God you've done really well, Serena. I'm very happy with where we are right now. You know, and it's resulted in you getting pregnant. So that in itself is a great result. You know, as one.
Yes, you called it a miracle. I didn't know that, because when you're on thyroid drugs, apparently I'm not supposed to get pregnant so easily. And it's a blessing in disguise that I am. So I went from stabilized to now I'm pregnant, which is already a natural form of stabilizing your thyroid, in your words, right?
Right.
So yeah, pregnancy was a blessing. Yay. But to put it the other way around, if I came in with hypo, how would you have treated it?
Yeah, so I'm going to put it on two sides. So let's say you were hypothyroid and you don't have enough thyroid hormone in your system. You feel that your whole body's gone from fifth gear to first gear to even no gear. So your all the cells in your body is missing thyroid hormone. So your heart, you just feel more what we call bradycardia. Your heart rate's a bit slow, a bit like an athlete. So you feel very tired when you wake up in the morning. You don't have any energy to go through the day. You probably need a bit of sleep in the middle of the day, and you find that even a doze off, you don't feel refreshed. And then your bowels, you become more constipated. You have dry skin, dry hair. It affects your mental faculties as well. So you feel that you're just not concentrating as much. So what I call mental fog. So the memory is just a little bit down as compared to before. You find that your other faculties, doing mental calculations, a bit slower. But generally, you just feel down. Sometimes some patients feel a bit depressed as a result.
Actually, I've gone through both spectrums, because on medication, before on medication, hyper. So these are the symptoms, not just that I've read, is that what I've gone through. You've got heat intolerance, you've got anxiety for hyper, and that feeling of getting a heart attack, losing weight, eating a lot, anxiety basically. And on the hypo spectrum of it, also something else that I went through when I was on medication, when I went to hypo, I'm losing hair, the dry skin, and the bowel movement is either really good when you're hyper or constipated when you're hypo. So you get spectrums of everything. I can say that because I've gone through all of it, right? So these are basically the symptoms of hyper and hypo. Can we say that?
Yep, that's right.
Yeah. Okay. So this month is Thyroid Awareness Month, January. What a month for me to actually pick to come out to talk about it, So you have a timeline of basically me as an example from the 12th December 2019, basically the whole year in January, going hyper to hypo to stabilize to now in January, I'm stabilized and pregnant, to give someone an idea of how a thyroid patient goes through their journey. So in about 18 months, say, normally people's journey is 18 months, right? So 18 months from now, from when it started, say this June, what are the chances of me not having to go back onto any kind of medication, you think?
So that's dependent on a few factors. So the big one, because the condition of the thyroid disease that you have is what we call an autoimmune thyroid disease, where your body attacks, produces antibodies that attacks the thyroid. That's Graves' disease. Now, those antibodies, if they are suppressed after an adequate amount of treatment, and usually that's between 12 months to 18 months, and sometimes up to 24 months, it's less than the acceptable limit, reference range, then the risk is very low. And what we mean by low is like 5 in 100, or 2.5 to 5% risk of relapse. So you got a 95% chance of success of remaining in remission. However, if you are a smoker, or if you are in contact with, secondhand smoking, like your husband or your partner, your family, literally sit next to you and they smoke in front of you, that smoke will reignite the body to make the antibodies to attack the thyroid again. So these are the risks that occur with this. Yeah. there are certain types of thyroid disease that's not affected by cigarettes. So, for example, if you've got thyroiditis, which is inflammation of the thyroid from, let's say, an infection. Let's say you got a flu recently or cold and it affected the neck and your thyroid's inflamed. So smoking doesn't play a factor with that. Or there are certain things that are drug-induced thyroiditis, inflammation of thyroid. So it doesn't affect that. But if you've got the autoimmune part, like Graves' disease, there is some molecule, I guess, within cigarette inhalation that if you inhale it, it goes straight to the thyroid and activates the thyroid problem or overactivity again. So in essence, we advise you not to be around smokers or do not smoke at all. So if you're on the tablets we're giving you, the carbimazole or propylthyracil, it just doesn't work either.
I understand. So you just brought a really good point here. There are many types of thyroid problems. Mine is autoimmune, but there are the ones that are caused by flu and other external factors. These are temporary ones.
Yeah.
How do you cause your thyroid to flare up like that?
Yeah. So the temporary ones a little bit more esoteric, and it's very difficult to distinguish this unless you do some blood tests, some radiological tests. But essentially, when we meet the patient in front of us, there are certain clues that are there. So let's say in the past couple of weeks, they've been down with a viral illness or flu-like illness, and the neck is sore, so it's really painful. They don't have the thyroid eye disease. They don't have any other features of autoimmune thyroid disease, which would be swelling of the legs. That's what we call pretibial myxedema. Or they have certain changes with their fingernails called acropathy. Those are changes that you would see with Graves, but you don't see any of that at all with thyroiditis. And thyroiditis is usually self-limiting. But it's quite a complex field, such, and to delineate each of the various subtypes of thyroid disease, and because the treatments vary, take a lot of teasing out with blood tests and ultrasounds and other radiological imaging.
So how exactly? So it's so complicated. So how does someone even know that it might be thyroid?
Yeah. So if it comes to you and you're just feeling generally tired, and people haven't been able to figure out why you feel tired or lethargic or lack of energy, or as we talked about earlier, the symptoms of, as you rightly mentioned, Serena, palpitations, sweating, tremors, diarrhea, anxiety, any kind of mood disorders, and that you think, oh, I need to check my thyroid in case it's overactive. And we talked about the underactive ones earlier. But the pressure in the neck, so let's say you've got pain in the neck, that's usually due to acute problem like thyroiditis. However, if you've got a swelling in the neck, it's been there for a long time, you should also get yourself checked out, because if you leave that too long, the thyroid gland, as I said, shaped like a butterfly, those little lobes on both sides, what I call, the size of a half a plum, will compress the middle windpipe or trachea, and you can't breathe or you can't swallow. So these are things you should come to a doctor to seek for advice.
So Dr. Saiful is an endocrinologist. Obviously, I was referred to you. Before that, I realized what I had when I did my yearly health check with my GP. So a GP normally cannot help you with specific thyroid problems. You have to be referred, right? So do they check for thyroid abnormalities at every health check, the annual health check?
Yeah, so the problem, it's probably, if I were to be frank, is that when you see a general practitioner, the test that they normally request is 1/3 of the thyroid function test. They do this thing called the thyroid stimulating hormone, or TSH.
Right.
Now that in itself is inadequate. Even when you go for health screening, they only do that particular test. So you miss the whole thyroid picture, because the problem may not just be here in the thyroid gland, but it may be a problem in the pituitary gland, the master gland.
Right.
So we as endocrinologists, we request the two hormones from the thyroid gland, the free T4 and the free T3, along with the TSH. And at the same time, if we suspect it's an autoimmune problem, we have to measure the antibody level. So
That's more detailed when you suspect that you have. Let's say, for example, I just want to be careful. I'm a normal person. I want to check my thyroid levels. Like you said, I should. Would I go to the GP or should I go to a specialized center to check for it? Lab.
Yeah. I think if you go to the GP and you don't have a full answer, I think it's important to seek for a specialist kind of like a consultation, because a GP may see the TSH as being normal, but the problem can be it can be inappropriately normal.
I understand
the whole picture.
Okay, what happened to me was I have a family of thyroid disease, so on both sides of my family. So it was easy for me to point out to my GP to say, do a more detailed test for T3 and T4 in my annual. But if you out there, you think you may have a problem, it's possible for them to ask for a more detailed test from the GP, right? For their annual health. Yes. Okay. Then you go to an endocrinologist like Dr. Saiful. So on to more general sense. We already know the difference between hyper and hypo. A quick Google and you'll find that as well. But how do you get thyroid? Like you said, there's acute and there's chronic, right? So acute are the ones that you mentioned just now, a lot of possibilities. And chronic is just someone like me living with it, with both sides of the family. Can I say that? Is that fair to say?
Yeah. Okay. Yeah, true.
I think so. So what did I want to say? Do you recover from thyroid? Like you said just now, it will be a lifelong of up and downs, right? So if I'm stabilized starting next year, how often would someone like me need to see an endocrinologist to get a blood test to make sure that I am stabilized?
Okay, so that's a really excellent question, Serena, because you've got to look at what's the underlying cause of the thyroid disorder, and then you'll know how often one should see. So as we talked about earlier, the commonest cause is this autoimmune thyroid disease, right? So self-destructive process where, as explained, the body's immune system attacks the thyroid cells, a bit like it thinks it's a foreign invasion. So this can recur at any time in the future.
Oh boy.
Right? So that's what we need to try and suppress. And how we suppress it, we suppress the antibody that attacks the thyroid.
Right.
So if you have family members who have thyroid problems or any other autoimmune disorders, so there may be autoimmune diabetes, arthritis, lupus, these are things that means your thyroid is at high risk of recurring in the future. So we ourselves, we keep an eye on that on a regular basis to ensure that that antibody that attacks the thyroid doesn't come back. So intermittently, in the first 1 year after we finish treatment, to watch out for any risk of relapse, we review the first 6 months post-treatment on a monthly basis, because the highest risk of relapse is in the first 6 months after we complete treatment.
Let's say I finish my medication this June, right?
Yeah.
So from June to December 2021, I will go see a doctor every month.
For the moment, because the risk is the highest at that time when we stop the treatment. It can just
and that is when you that's when you take blood tests every month and you do the consultation.
Yeah.
But no meds.
No meds. Yeah.
I
no meds at all. And I think if we want to tie that to, let's say, the greatest thing that's happening, which is getting pregnant, for example. So when you are pregnant as well, that has a huge implication. So that's why having regular review early on will ensure that the thyroid remains stable, so that you reduce the risk of the antibodies in the mom. It's really crucial for the first 6 months anyway, to keep an eye on things. Now the risk sort of goes down for the latter 6 months. But then if, let's say, first 6 months is okay, the review is sort of widened towards every 8 to 12 weeks, depending whether, patients feel okay or not as well.
So basically, if I have a chronic I'm thinking about anti-inflammatory, chronic autoimmune thyroid disorder, my relationship with my endocrine will be lifelong.
Yes.
So it's like every Friday they tarik lah.
For like 20 years,
Oh, no, it's good to have an expectation, for people who may think they have a thyroid issue, to not have such a short-sighted view of it, because at first I thought I was going to stop seeing you after 6 months also. But here we are. And it's not a bad thing because Dr. Saiful has a very pleasant face. I saw in a lot of sites that your relationship with your endocrine is very important, because if you cannot answer my questions, or I'm not getting the answers from you, then it's going to be even more frustrating for a patient. So if your endocrine cannot answer your questions or make you feel at ease, time to switch. So it's a good thing that Dr. Saiful is here, because he really puts me at ease at each of my meetings with him. So to round things up, we know hypo, and we know that Graves is one of the most common one in women, and one of the most common thyroid problems, right? That's what I have, what I was diagnosed with. On top of Graves, I had thyroid eye disease, which can manifest in some patients and some might not. In me, it's just very obvious. So this is thyroid eye disease. Okay, we'll talk about that more, because at some point in 2020, I was seeing 4 doctors. So wonderful 2020 it is, but it's better to be safe than sorry, right, doctor? To see 4 doctors and put myself at risk for COVID. Thank God nothing happened. I was at the hospital a lot. But seeing all 4 doctors kind of mapped out what actually is, up with my body. And it's very important for you to know what is up, so you know what the next course is. Right now, what would you like to add to this month, Thyroid Awareness Month? What would you like to tell people out there?
There is a huge amount of, I wouldn't say lack of awareness, but people think a thyroid problem is a small spectrum and it disappears, as one would say. The big thing is, if you have any symptoms that's unexplainable, whether it's lethargy or you think it's a heart problem, and the doctor that you see thinks, it's a heart issue, ensure that the doctor actually checks your thyroid function test. If you're lethargic, it could be a lack of thyroid hormone, or even too much. There's another thing I forgot to say earlier, which is there is a relationship between, at times, vitamin D deficiency.
Yes, vitamin D. But you know what? You have to catch that in the next episode, because we actually have a few episodes of this. And I do actually touch on vitamin D. But before we wrap things out, I also forgot a point. Stress. How much of a role does it play in your thyroid function? Stress.
Yeah, so stress plays, it's like a vicious circle. Stress can induce more production of thyroid hormone. But as well as that, if you have an autoimmune thyroid condition where your body inadvertently anyway is just pushed towards overdrive, all the cells in overdrive, that pushes you into a stressed kind of like feeling. So therefore, one leads to the other, and it keeps on going. So the best way to avoid stress, we sort of take the easy option and put our patients on medical therapy, whether it's be like a beta blocker, which is the propranolol or Inderal, that just slows all the cells down. Now, in women, it's kind of easier because it just slows the heart rate down. But in men, it actually, if we use it at high doses, can lead to erectile dysfunction. So beta blockade, we usually warn our male patients that that's the risk of that. But it is a highly effective treatment,
Right. Oh, no, but stress, looking at it the other way around, how much of a role does stress play in preventing thyroid, for example? Can you not prevent, but prevent, try as much as you can to prevent thyroid? If you try to lower your stress, can it kind of not stop, but prevent thyroid in any way?
So if you're in a situation where you go on a holiday and you have a huge amount of endorphins being released, you're feeling relaxed. So therefore, as a result, your heart rate is a bit slower. You don't have that consequence of palpitations or the tremors and sweating and all that. Yeah, so it sort of, to a certain extent, equilibrates your thyroid hormone level. It doesn't cause that surge as such. So as I said earlier, stress at work, stress from any other factor pushes up your heart rate, and guess what happens? Your thyroid just starts to go up as well. And a vicious circle starts. So it would be ideal, but it's really difficult for all of us as humans to have no stress at all in our life.
Of course.
So having yoga or some sort of relaxation therapy, meditation helps as well.
Speaking of which, because all these external factors do actually affect your thyroid, in our next episode, we're going to talk about external factors, exercise, and how diet can actually help you control your thyroid function. So that will be next. Thank you right now for the beginning, Dr. Seipel.
Thank you.